Hello again, everybody. This is a mini lecture on behavior therapy, and I hope it finds you well and safe. Stay that way, okay? Good deal. So, behavior therapy is arguably the most scientifically based kind of therapy because it allows us to measure the effectiveness of the techniques that it uses and to look at outcomes in a way that is more definitive. Okay? Some of the big names are B.F. Skinner, Alfred Bandura, Arnold Lazarus, and others. Yeah? So, let's see. I want to start off with the philosophy of behaviorism. Behaviorists believe that all behavior, in particularly maladaptive behavior, which is what people would be coming to you to do away with and replace with a more adaptive kind of behavior or behaviors, the result of either classical conditioning, in which you might be treating, say, phobias, operant conditioning, which has a role in the development, certainly, of addictive disorders, and then observational learning, where we observe others and copy them, and those become inculcated. Okay, so one or more of these kinds of learning are implicated in the development of psychopathology. Okay, so let's think about this. The basics of this therapy are that overt behavior is the focus, not what someone feels, and not their stories from the past. There is no excursion into the corners of the development of these sorts of things from early childhood, for example. They're very much interested in what's happening now, what the behaviors are, what the maladaptive portions of those behaviors are, and what the goals are going to be, and then, of course, to develop a treatment plan. And all of that is measured on an ongoing basis. So overt behavior is the focus. And then learning how these behaviors can be shifted to new behaviors or supplanted by new behaviors is the core of the counseling. So the treatment is very active, very directive, very collaborative, and we're able to use empirically supported techniques. Okay? And what that means is that for those of you who like more structure, this could be a kind of therapy you would either like to learn in being a therapist or benefit from as a client. Okay, so if we're going to say it generally, normal behavior, just like abnormal or problematic or maladaptive behavior, is learned through reinforcement and imitation in one way or another. And abnormal behavior, in particular, is a result of some kind of learning process that is faulty. All right? So we want clients to take this active collaborative role. We want them to be responsible for making the changes, working towards the goals, and so we're going to help evaluate how they're doing, and so will they. But they have to be willing to be guided by the treatment process. Okay, that's something they must be guided internally to strive for. Lots of different techniques. If you like a lot of techniques, here you go. Reinforcement, shaping, modeling, systematic desensitization, relaxation methods, flooding, assertiveness, also, even mindfulness has a role here, coaching, behavioral rehearsal. So one of the things we do is almost invariably have a treatment plan that the client helps you come up with based on your experience and explaining why you think one thing will work better than another. and then assigning homework for them to do. Yeah. And you're going to have contracts about that. You'll have some written contracts in which they sign and you sign that they agree that they will work on these things. It makes it more concrete when they do that. Okay? So in behavior counseling, we do not provide insight, and if they gain insight, great, but if not anything related to the goal setting. And we treat symptoms, not the causes. We don't go back again into a foyer of the origins of disorders. And so, lastly, and this could be true of almost any counseling, is that the treatment should be as brief as possible. I mean, the goal of counseling is to, in an expeditious way, provide that clients are able to handle their issues well enough that they don't need you anymore. Yeah. I'm chewing on something or other here. Cough medicine. So, positive regard that was so important in the previous kinds of therapies, person-centered, Gestalt, existential, but positive regard, it's not necessary. Positive expectancy by the client, credibility is important, being the treatment specialist. But, this is generally not an issue. However, we figure out that there are things to like, at least in every person. And because every person is a human being, the respect and regard we have for them in that way is transmitted. So I want to talk about a couple of things. One is exposure. Exposure means that at some point in the treatment, they're going to be exposed to the things that they fear doing. That is a critical issue. So you can't get beyond the anxiety of an item, a situation, a circumstance. You can't get past that until you are ready to expose yourself to it and move beyond it. Okay? And this has to do with the fundamental idea of what anxiety is. Anxiety is not a bottomless pit. It is a thin layer that feels bottomless. Excuse me. So we treat anxiety disorders in particular, like phobias, for example, by using either what we call imaginal exposure, where they're imagined first in your office, later at home, what they're afraid of, in steps perhaps, from lowest to highest. That's a form of desensitization, systematically doing so. And then they either, in that way, imagine being close to that item, or they do it in vivo, which is, in reality, they do that. Excuse me. Now, this has been used in PTSD. Yeah, one of the treatments for PTSD in combat soldiers has been the use of prolonged imaginal exposure in therapy offices, and what you do is recount the difficult memories over and over and over again verbally and bring up the images. And in addition to some homework assignments, eventually the person begins to realize the anxiety was just a thin layer. You become adapted to hearing, seeing, and so on that feared imagery, and with experience it no longer has that effect on you of anxiety. But this exposure is not just for PTSD, although you should know it's being looked at in all sorts of different places where PTSD might develop. Vietnam veterans, the Angola Civil War, you name it. Another kind of exposure is virtual reality, VR. And this is a big thing for combat soldiers and others. OU Health Sciences Center has a lab set up with all of the ways that can trigger memories for you that are slowly brought to your attention. For example, you'd be standing on with virtual reality goggles, seeing a scene that is very much like what took place for you that you have trauma regarding. And that platform you stand on will vibrate. If you're in a vehicle, it'll vibrate. You'll have sounds, smells, even a nasal puffer, a heat lamp for explosions, all sorts of things. And one by one, from lowest to highest, those stimuli are offered, those triggers, if you will, are offered. The first one over and over and over again until you no longer have a response to it. And then the next one is added, keeping the first one in place. And so eventually this can be very useful. Now you have to, at many VAs, and this is true of OU Health Sciences Center, you have to fail at the other levels of intervention, including medication, individual therapy, group therapy, those sorts of things, unfortunately, because a lot of times those don't work. Okay, so the idea of exposure is critical, and the way you expose has to do with your resources as a clinician and the nature of what the client is up against. Now, in a sense, exposure is done much like what we call the straight-up intervention called systematic desensitization, in which the person creates a hierarchy from lowest to highest of, say, between 10 and 15 items, moving from lowest to highest level of response and anxiety, and they'll learn to relax themselves before they begin to imagine or expose themselves in real life to those items, and over and over again, so that one becomes no longer any source of anxiety. Then you go to the next one. So, and depending on how fast they do that, this could last anywhere from 8 to 10, 15 weeks on up to a couple, 3 months maybe. Yeah, 3, 4 months maybe. This is a relatively short-term therapy. Okay, flooding is another one, and this has to do with putting someone in a situation where they are all of a sudden confronted with what they're afraid of. So if you're afraid of snakes, you will first learn how to relax yourself very deeply, which is a part of all of these, by the way, all of these techniques. You get very good at that in the therapy session, and the homework you do elsewhere will be a part of that. And then you will be placed within the therapy office in front of what you fear. So if it's a snake phobia that you have, a snake will be brought in a tank, and then there'll be maybe a drape over it, and then the therapist will pull the drape. Oh, you're going to get anxious, so you relax yourself, which you're good at now. And then the cover comes off. You're going to get anxious, you relax yourself, and then the therapist picks up the snake and holds it a few feet in front of you. You're going to get anxious again, and then maybe you touch it. You see where we're going with this. So this is very quick, but you have to have a client that's able to do this, and the thing that they're afraid of has to be something that can be presented in the therapy office. So if you're afraid of blimps, I'm afraid you're out of luck. Okay, so you can also use something called aversive stimulus. Aversives are essentially a form of punishment or uncomfortableness, really. An example of this would be a drug you could take that makes you vomit if you get in the presence of alcohol, so that people who are highly motivated, willing to take the medication daily, will throw up if they have a drink. And what happens is, after a time, they don't need the drug anymore because they're training their brain to get sick in the presence of alcohol. So they'll actually just get sick without the medication eventually if they take a drink of alcohol. Again, takes a very motivated client. I'm busy looking for buttons here that I'm trying to look through an outline for you here. And then the last thing, just as another example, is assertiveness. So assertiveness is where you learn the behaviors, nonverbal and verbal behaviors, associated with, in a dignified way, standing up for your boundaries and rights while protecting those of other people. This can be done most effectively in a group, could be done to some degree individually, but not as effective, perhaps. So yet another example. So that's behavior therapy, and what we'll do next is cognitive behavior therapy. Watch for the discussion question, folks. Bye-bye.